This is Chapter 4, Validating and Documenting Data. The objectives for this chapter are defining the validation of data, describing the steps of the validation process, the conditions and situations that might require the data to be rechecked or validated, discussing several ways to validate the data, the purposes, guidelines, and rules of documenting and assessing data, discussing the assessment findings and a variety of different types of assessment forms. Using the significance that the honesty and documentation expected by the Nurse Practice Act and the Joint Commission, and the importance of documenting assessment findings in the legal record, the advantages and disadvantages of electronic documentation, and the key principles of honest and accurate documentation. So when we validate data, we are verifying that the subjective and objective data are reliable and accurate to the best of our knowledge. Any errors during this assessment can cause our judgment or others to be made on unreliable data. So inaccurate data causes poor clinical judgment. And this could lead to diagnostic errors, not just for the nurses, but all the healthcare team. So it's crucial, and the assessment is the crucial element in the first step of the nursing process. So we decide if data needs to be validated, and how are we validating the data itself, and what areas do we need to ask more questions if the data is missing. So sometimes there's a discrepancy or a gap between what the patient says and some of the objective data that we find. For example, if the patient says, I'm feeling happy, but they appear very sad, or if there's a discrepancy and maybe a past history, something, you have a medication that's on their record and the patient forgot that they used to take that medication. So validating, asking these questions, reiterating data from their chart. We do that all the time when we're giving medications. We're constantly talking to them about the medications, talking to them about the dosages, making sure and validating that we're on the same page with the patient. A lot of times patients forget to tell you things right off the bat. So we're always going to be asking questions and talking to them, validating things. Another thing you might see with objective data is maybe the patient has an elevated temperature but doesn't have any sensations, or the patient's skin doesn't feel warm. That may not click with you, that may not make sense to you. So we might want to validate that temperature value. Did the patient just drink something hot? And did that skew your temperature? We might want to look that up. If you're doing a temporal temperature, was the patient sweating? That might skew the result as well. So that's when we would want to validate those findings. So some of the methods of validating would be repeating the assessment, clarifying with the patient, always asking but verifying. It's not that we just want to be repetitive, you just want to be safe. You also can ask other healthcare professionals if you are coming into a situation where you would like somebody to help you. You can always ask, hey, charge nurse, I'm struggling with trying to assess this pulse here. Can you come and validate that this patient has a diminished pulse, pedal pulse? There's nothing wrong with having somebody come and validate your findings. And that's how the patient really wins. When you go and have somebody concur with your findings, that's very important. So comparing those objective findings, the subjective findings, you're going to fill in the pieces of the puzzle so you can make the best clinical judgment. So there are some times that initially questions have been overlooked. Maybe when you're talking to a patient, the way their responses might lead you to ask more questions, but getting more information is always helpful in understanding what's happening with your patient. So when you're performing assessment or gathering data, and your patient has a finding, you might talk to them and say, is this new for you? Have you been dealing with this for a while? If, for example, your patient smells of smoke, but they deny smoking. You might ask them if they've been around somebody who smoked, something like that. Secondhand smoke, as we well know, is a concern as well, for risk for patients. But understanding what's going on with the patient, how can we help? We have to start with accurate data. So purposes of documentation, we are chronologically documenting the patient, our interventions with the patient, their assessment data. We want to see the trends of the assessment findings during their course of care, because sometimes those things change depending on the interventions. And we can actually see if something is helping or if things are not going the way we would expect them to. So we want to make sure the client's information is put in the chart where the entire team can look and see what the status of the patient is all throughout the day, so we can make adjustments as needed. There may be additional screenings or validating things that need to occur. So accurate documentation is very important. Accurate and timely documentation. So there may, depending on what's happening, we might have opportunities to provide an additional education to patients, especially if we need to validate something or we're noticing some trends in some way. That might give us an opportunity to provide education for your patient. The documentation for care in the hospital and what the patient's needs are, also, as you may well know, a source for what we submit to insurance and financial reimbursement. So the acuity of the patient, the Braden scale tools, your skin assessment, your falls risk assessment, your DVT prevention assessments, all of the documentation of those interventions that you're completing is so important to our financial partners. These parts of your documentation are a legal record. So this is care that you gave the patient or care that you omitted to give the patient. And you have to have, as the nurse, your clinical judgment has to be prudent, that you're doing everything you can to keep your patient safe. And your documentation is what's going to provide that for you. So the client's acuity system, the Muse, is also dictated by your documentation. If you're documenting your patient has a change in their confusion or they have a new onset of delirium, that is going to change their acuity. If they are an increased fall risk, that changes their acuity. So it's very important that you have an accurate documentation of the care that you're providing. It also helps to provide data and compliance with all the legal and accreditation, professional standards of your Nurse Practice Act and your Joint Commission standards. So your subjective data that you're documenting is all your biographic data, health concerns, your past health history, family history, lifestyle and health practices. Your objective data includes all the data that you gathered from inspection, palpation, and auscultation. You very atypically will do any type of percussion in the hospital setting. So all this information helps give the data for the problem for the patient and gives a baseline for ongoing assessments. So you're going to use an electronic health record. Many systems are called Epic, or you're going to hear other ones, I think. So these are databases, and they link your radiology and your lab and your medication records and your physicians all together with other healthcare departments. So everybody can, who's working with this patient, the healthcare team, can access the notes and this information and the lab values and the vital signs, everything to help make the best care decisions for the patient. And so if we all have access to that, it eliminates repetition of doing the same lab values and x-rays multiple times because everybody can see the same information. So we as nurses are involved in informatics, and there is a whole department called nursing informatics that works in this area because that talks about the charting that nurses do. And so there is a whole situation that we work with some of the software systems to help facilitate some of these documentation. The electronic record was some of the Affordable Care Act pieces were to try to get everybody on an electronic health record to improve quality and safety for the patient and efficiency for the care. But you still have to maintain privacy and security of data, which means you can't leave your computer screen up. You don't want to go into a patient's room and open up a computer screen where anybody can have access to it in the patient's room. So still making sure you maintain privacy of your patient and security of their data. So when we're documenting, you're going to keep information confidential. That's verbal, written, all documented information in the client record. If you print out a report sheet, that must be destroyed before you leave the hospital setting. You do not want to take any client information home with you. If there's not electronic record, any documentation, legibly printing neatly, if you are signing consents, things like that, you want to make sure your writing is legible and neat. Using correct grammar and spelling. We talk a lot about this when you are, before you send an email, read it to yourself. Just read it out loud to yourself or read it to yourself. If it doesn't make sense when you're reading it, it is most likely not going to make sense when somebody else is reading it. Always use correct grammar and spelling. It's just an indicator of professionalism that you took the time to read your own work. If you're putting your name behind something, you want it to be as good as possible. You're going to avoid any wordiness or any judging type words or opinions when you're documenting. You never want to say, I think this. That is not objective. So objective, unbiased phrases are ideal in documenting data. You're going to use phrases instead of sentences to record data. We're not doing full paragraphs when you're documenting in the record. You always record the findings as the evidence for your judgment, not how they were obtained. So then we record the client's understanding and perception. You're going to do that in quotes if it's word for the patient. Always avoid normal. What is normal? Normal means nothing because what is normal for one person may not be normal for another person. Always record complete information and details for the client's symptoms. And supportive objective data if there's any specific observations. So some of the assessment forms that require your documentation is the initial assessment form or the admission form, your ongoing assessment form, which is in the electronic health record, your shift assessment, and then a focused or specialty area assessment form. Sometimes we do that when we do a pain assessment or pain reassessment. Some verbal communication of findings. Sometimes you have to report to another person when you change shifts or to another healthcare provider or to a physician when you're speaking to them on the phone. So we use the same, the method of data communication like SBAR. If you're doing a face-to-face, you're always going to utilize eye contact, ask questions, allow time to answer questions. You're going to provide any documentation or data that you're going to share. And then, especially if you're on the phone, you're going to allow them to speak back what you had said, to do a read back. If you are, especially if you're sharing values, or if you're um, calling about an emergent situation, you want to make sure that the message is loud and clear. Um, and always when you're documenting those things, document who you talk to and the time and date. So SBAR is situation. What is happening with the patient? Why are you calling? The background is the events that led up to the situation. The assessment is the objective and subjective data. And then the recommendation is what I would like to see happening from there. So in summary, you're going to bring all these pieces together. And hopefully this will help you in understanding the very, very important rules and expectations for validation and documentation.